Welcome to the Stronger After Stroke podcast. I'm your host, Rosa Hart, the stroke nurse navigator for Norton Healthcare. Today, I get to interview Dr. Daniel Sean Stewart. He is one of our interventional cardiologists, and he's here today because he does a special service for people who are at risk for and have experienced stroke related to atrial fibrillation. Thank you so much for taking time to be with us today.
Thank you for having me.
And I especially wanted to invite Dr. Stewart today because when I worked in the ICU, I saw his interactions with patients, and I could really tell how much it means to him, and he really cares. And that really informs a lot of the great work that you do. So I wanted to bring that out.
Well, thank you. I appreciate that. I've been inspired to be a cardiologist ever since my grandfather had cardiovascular issues many years ago. And I think that's led me on this journey to help patients as much as possible.
Definitely. Would you say, what would you say is your why?
That was sort of my initial motivation, was dealing with issues related to my grandfather, but then just trying to do things. How can you make an impact on people in your community? And I have some unique gifts, I think, that allow me and afford me the opportunity to do that. I've been really privileged to work with Norton Healthcare in helping us expand our clinical offerings over the last decade.
And now we have the Norton Heart Vascular Institute, which is a really big deal.
Absolutely.
And you're a big part of that. And we'll talk more about some of what goes into that.
Absolutely.
So a lot of people experience a stroke and they hear about this thing, atrial fibrillation, that they've never heard of before. And their doctor wants them to wear a heart monitor to look for it. What is atrial fibrillation?
Well, atrial fibrillation is the most common arrhythmia that we deal with in cardiology. And it's in essence where the upper chambers have gone into a disorganized or chaotic rhythm. And there are a wide variety of clinical reasons why that occurs. One of the most common causes, for example, is longstanding hypertension leads to stretch on the left atrium. When the heart goes out of rhythm and the atrium are quivering, the flow slows down in that atrium. And there's a part of the left atrium called the left atrial appendage, and it's in that pocket of the atrium where, because the flow has slowed down because of the arrhythmia, that clots actually form. And then those clots can break free and go to other parts of the body, including the brain. And when they go to the brain, they cause a stroke. Mm-hmm. And so atrial fibrillation is exceedingly common in the United States. Almost 10 million Americans have atrial fibrillation. And we anticipate by 2030 that over 12 million Americans will have atrial fibrillation. And with that, you see almost 800,000 strokes. One stroke occurs every 40 seconds, and 1 in 6 patients with atrial fibrillation present initially with a stroke. And unfortunately, the strokes with atrial fibrillation are quite debilitating. They're usually larger. They usually have more deficits. And as you get older, you start thinking about it's not just quantity of life, it's also quality of life. And what, as you get older, can impact your quality of life. And a stroke 70+% of patients who have atrial fibrillation related strokes have significant debility or death related to the process.
Yeah. And I know you and I have worked with a lot of people who have experienced that, and we're both really passionate about making sure we prevent that as much as possible.
Absolutely.
While there are great innovations in recovery, prevention is better than a treatment, right? So,
absolutely.
Why are you using the Watchman device as a means of prevention?
So, and one of the ways that we prevent clots from forming in the heart when you have atrial fibrillation is we put you on blood thinners. And those blood thinners reduce your chances of having a clot in the heart, but also increase your risk of having other bleeding related issues. And so for those people that have bleeding or have a propensity to have bleeding issues, we feel that the Watchman device, by plugging that portion of the heart where the clots are most likely to form, we can make a substantial impact on reducing their risk of stroke without subjecting them to the risk of blood thinning.
Yeah, and that risk versus benefit is always a big conversation. How does a patient know if they're a good candidate for a Watchman device?
Well, I mean, I think you have to do that in conjunction with your cardiologist, but by and large, a wide number of patients who have atrial fibrillation are likely candidates, provided they have enough risk factors that they get to the ACC/AHA recommendations for anticoagulation. Most of those patients qualify if they have a logical reason to seek an alternative to long-term blood thinning. Those logical reasons could be I fall frequently. That logical reason could be that I bleed frequently. And that could be, bleeding from the stomach or the bowels. That could be, bleeding from the, mouth. That could be bleeding from the urinary tract. There are a variety of logical
Could it
reasons
be
that
a
have
lot of
manifested.
bruising?
Could be very much easy bruising and bleeding. We see that not infrequently. That's one of the more common reasons that we implant.
Yeah, and that's a very visible sign. People see that one. Yeah,
And particularly with our patients that have concomitant coronary disease, one of the things we see is, they need an aspirin or other antiplatelet drugs to go with the blood thinner, and that increases the risk of bleeding and the risk of bruising, and that's where Watchman can come into play.
yeah. So then there's a chance after they have that place, they won't need to be on that medication?
That's correct. So in essence, the idea will be in 6 months, everybody would only need to be on a baby aspirin. Now, how we get there are two different sort of blood thinning pathways that we sort of talk about. One involves using aspirin and an aspirin-like drug together, two drugs initially. Sometimes, depending on clinical factors, we think about putting people on blood thinners for a short period of time and then doing additional imaging before we remove the blood thinner entirely. But ultimately, at 6 months after implant, everybody would be eligible to just be on an aspirin from the Watchman perspective.
Excellent. Can you walk us through the process of implanting the Watchman device, and is it considered a major surgery?
So this is a relatively minor, minimally invasive procedure. Now, we do put people under general anesthesia, predominantly for comfort. We don't want people moving around. We usually put a scope or an ultrasound probe in the esophagus or the food pipe of the heart to sort of look and guide our imaging. Sometimes we also use some imaging guidance from a catheter we insert through the leg. But basically, we go up into the big vein into the leg, and we go into the right side of the heart. And from there, we make a small hole in the upper chambers of the heart to go from the right side to the left side. And that hole heals up on its own, and it's made safely by a little electrocardiogram device that we have. And then basically, we find the left atrial appendage, which is an outpouching of the left atrium that, by the way, serves no purpose. It has no function. It's probably some sort of embryologic remnant from how we've evolved over time. And basically, we put the Watchman device in. And the Watchman, for lack of a better device, is this ball-like device that serves as a plug that we put into that device. We have various sizes, and we use the ultrasound technology that we talked about, to sort of measure the device and make sure we get the right one. And if everything looks good, we unscrew the device and release it there, and we pull everything out. Usually takes us about 30 minutes. Did 3 today, as we just talked about. Usually takes us about 30 minutes to do it. And then most people are in the hospital overnight, and then, light duty to allow this leg incision to heal up for about 5 days. And then most people are back doing their normal activities.
That sounds pretty easy.
Yes, I mean, it's a very safe and effective procedure. They've been studying Watchman since the early 2000s, and this device has been commercially available since 2015. We were one of the earliest adopters in this community, and are the highest volume center in this community in terms of devices. We just finished part of our enrollment in one of our recent trials, the Champion trial.
Mhm.
We're also part of the Option trial. So we've been involved in some of this seminal work with this device.
Yeah, I really appreciate your leadership in this area. It's so important to give our community more options to choose from, especially those that can prevent those bleeding risks we talked about. Um, so then, You already talked about the activity restrictions, that they're minimal. How effective is the Watchman device in preventing strokes compared to blood thinners?
So I want to talk a little bit about safety for a second. So over 500,000 plus devices have been implanted nationwide, 99% success rate. The complication rate's well less than 1%. Both nationally, our experience is even better than the national experience. In terms of efficacy, you see a 90, so if you're on blood thinning, you prevent clot from forming in the left atrial appendage. You also prevent clot from forming in other areas. Obviously, if you're not taking blood thinning, clot could form in other areas. If you just plug that left atrial appendage, you reduce the strokes by about 95% in comparison to if you were actually taking blood thinning. So that's a really good trade-off to not have to take the blood thinner and deal with the nuisances of recurrent bleeding or the easy bruising. So very safe and effective.
Excellent. And then, are there any risks or complications associated with the Watchman procedure?
Again, emphasizing the safety profile of less than 0.5% device-related complications. We talk about, devices, migrating or moving. That rarely occurs, 1 in many hundred. I think you talk about, anytime you're doing procedures within the heart, you could potentially make little holes in the heart or damage the heart. Knock on wood, we have not had that happen in our 10 plus years, in part because Norton's has provided me the safest equipment possible to make the little hole in the heart, to put the device in, and that is really helpful in that regard. But there are all small risk of arrhythmia or irregular heartbeat associated with this, but by and large, this device is very safe and effective.
And they probably already had that irregular
That's
heartbeat
correct.
we were
Very
talking
many of them
about,
have,
and
yes.
that's a pre-existing problem. Yeah. So, what kind of follow-up care is required after getting the Watchman device implanted?
So we usually do some sort of imaging, and that imaging is either a transesophageal echocardiogram or a scope down the back of the throat or a CT scan. We often will do a CT scan, but ideally we'll do a CT scan beforehand to map out the procedure. We'll do the procedure as we talked about before, and then somewhere between 45 and 90 days after the implant, we will end up doing another scan to evaluate the device and making sure that it has healed in effectively and efficiently and that there are no leaks or gaps and that it's all covered.
Excellent. So, we talked about how the goal is for them to be able to stop taking blood thinners if it was just for stroke prevention. How is that decision made as to whether or not that's safest for that person?
In terms of stopping the blood thinners. So,
Yeah.
so we look at once we get the device in, then we make a determination at the time of implant which one of the two pathways this patient will go down. Do they just get aspirin and another aspirin-like medication called Plavix? And we would do that just for 6 months. Or we do, if there are other factors that make us think that they might be higher risk for clot formation, we would end up doing aspirin and then maybe a blood thinner for 45 days. Then we predicate the next decision point is based on the second CT scan we do. We look at that CAT scan or computed tomography scan of the heart, looking at that appendage. If that all looks good, then if you were on blood thinner, we transition you off blood thinner at that point just to aspirin and that other medication that's like aspirin called Plavix. If you're in the aspirin and Plavix arm, then we just continue that. At 6 months, if everything looked good on that CT scan, then we stop that Plavix medication and just leave you on aspirin.
All right. So, what advice would you have for caregivers who are working with somebody who may need a device like that implanted? Do you have any encouragement for them if they're feeling anxious about the procedure?
Well, I guess I would have some. So, if you are a patient or you're a caregiver of a family member and you're seeing this podcast, you probably are associated with a cardiologist if you have atrial fibrillation. If you're not, maybe you should be, but I would be asking either my primary care provider or my cardiologist about this procedure and a potential referral where we can talk to you in our structural clinic about the risk, benefits, and alternatives. For those that are anxious, I often harken back, and this is what I use when I talk to patients in the office, which is what would I want to do if you were a relative of mine? And by and large, in the vast majority of cases, the risk of blood thinning continuing are higher than the risk of bleed. I mean, the risk of blood thinning and the risk of bleeding are higher than the risk of the procedure, because this procedure is so safe and so effective. And, I don't want to say free of complications, but with minimal risk of complication.
Yeah. And that's the best testimony. What would you do? Right. So I really appreciate you taking the time to explain this, which is new to a lot of people, and just kind of demystify the process. So if you want to know more information, feel free to reach out to us at Norton Healthcare. If you've enjoyed this episode of the Stronger After Stroke podcast, make sure you like and subscribe wherever you're listening, or if you're watching on YouTube. And leave me a comment. Let me know what you're interested in learning more about, and that can guide where we go next. So I will see you in the next episode.